Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 222 of the Better Health Guy blogcast series. Today's guest is Dr. Tami Lyday, and the topic of the show is EBOO and TPE, breakthrough therapies for chronic illness. Dr. Tami Lyday has been a physician since 2006 and a functional and integrative specialist since 2017. Prior to that, she spent 11 years as a family practitioner, but was never quite satisfied with conventional medical approaches. Her mother's illness and subsequent side effects of traditional treatments prompted her to learn more about integrative medicine, and she has not looked back. Dr. Lyday believes functional and integrative medicine is the best way to ensure lasting recovery, as it helps patients determine the root of their health issues and does not rely on medications that treat symptoms while ignoring the underlying cause of illness. She pursued training and certifications in functional and integrative medicine, including specialty training and certifications in the treatment of mold-related illness and Lyme disease. At the time of her certification, she was one of only 26 practitioners in the world who were Shoemaker certified in mold treatment protocols. After 4 years as a functional and integrative medicine practitioner, she opened the Lyday Center to provide a dedicated resource for people who are suffering from mystery illnesses and ailments that don't respond to conventional treatment and are seeking natural solutions to their chronic illnesses. Since that time, she's expanded her specialties to include the treatment of thyroid disorders and overall energy levels. Her mission is to heal the world one patient at a time. And now my interview with Dr. Tami Lyday. Today, I'm excited to have with us an expert in the realm of mold illness, chronic Lyme disease, autoimmunity, and many other complex chronic health conditions. Dr. Tami Lyday uses several advanced techniques such as EBOO, or extracorporeal blood oxygenation and ozonation, and also TPE, or therapeutic plasma exchange. She uses those tools to support her patients with challenging chronic illnesses. And personally, I cannot wait to learn more about these emerging topics from her today. Thanks so much for being here, Dr. Lyday.
Thanks so much for having me, Scott. I feel like the honor is mine. I feel like I have definitely been hit a new rank when you asked me to join you today.
Oh my gosh, the honor is mine as well. So let's start by talking a little bit about kind of the path that got you to doing the work that you do today, to the passion that you have for helping your patients. I know that your mom had a health journey. I know that you also had your own health challenges that fortunately you were able to completely overcome. So talk us through that path that got you to the place that you are today.
So I was just a conventional doctor, enjoying easily giving people a drug for an ill, right? And then creating new symptoms and it being super easy and 12-minute visits, 8-minute visits. And then my mom came down. She actually came down with breast cancer when I was in my residency in Illinois. So basically, the beginning of my journey into functional and integrative medicine started with helping my mom because she had breast removed and implants, and then she became an autoimmune patient. And as her autoimmune diseases flared, I learned more and more to try and help. So the first thing I did was I became an acupuncturist because she had chronic pain. So acupuncture worked really well up until a point. So it was like each time my mom got to a certain point where my tools in my tool belt stopped helping, I was like, okay, there's got to be another tool out there, right? So went and found it. So when I got her basically stable or minimally compliant or both, because it gets, as you guys know, as you watch Scott and you hear all these things, doing this journey is difficult. It's a lot of time, it's a lot of investment, it's a lot of heart and soul that you have to put into it. So she kind of dropped out of following the functional journey, and then I concentrated on myself because I had had chronic daily headaches that started probably around six years old. And I had never thought anything of it. I mean, I'd seen neurologists, I'd seen the best neurosurgeons in the world. And basically, all they told me was, you're just going to have to take a Vicodin. Like you're going to have to be Dr. House because we can't find anything that's physically wrong with you. I didn't take that as an answer. I didn't believe that I was going to have to take a pain medicine for the rest of my life. That seemed too suspicious to me. I had had exposure. I'm originally from Chicago, and I would go to summer camp up, actually, ironically enough, near where I live now in Eagle River, Wisconsin. And I remember, now that I do this work, I remember one summer that I won the award for the most mosquito bites and the mosquito bites with the biggest bullseye rings around them.
Oh my gosh.
So I probably had Lyme and co-infections from the age of 12. I grew up in a home where my mother still resides with her autoimmune disease, where the basement would flood. Anytime we'd have a big rain or anything, it would come in through the basement. And in typical Illinois style, we would go down there with the shop vac, zip everything up and we'd consider it done, no problem. So obviously after I became a mold expert, and I had her place checked, and we found it was incredibly moldy because what is it? It's like one of those 60s basements with like the wood on the walls. What does wood do? It attracts mold. We never dried it out. We never got rid of it. I still trigger when I go to visit her. But, obviously I had mold exposure from the time I was, a little bumpkin. We moved in there when I was 2.5 and started getting those headaches. I remember I was interviewing with one of the big names in functional medicine when I decided I was going to do functional medicine full time, and I was waiting in his office. And as most doctors run behind, he was running about an hour and a half late for my interview. So looked on his bookcase and was like, oh, I might as well read a book while I'm waiting. And it was Richie Shoemaker's Surviving Mold. So grabbed that, and in the hour and a half, beautiful thing, I was able to read the whole book. After I left there, I called myself in cholestyramine, took it for 3 days, and my chronic daily headache that I'd had since I was 6 was gone. So I was a fan. I knew. I actually called him the next day to get certified. I was like, this Shoemaker guy, he's on to something. I want to be a part of it. So that's when I added Shoemaker certification in. I'd already done my IFM certification and was using that with patients, but as always, just kind of like with my mom, anytime I hit a wall and found something that, there's always one patient that doesn't respond. You think you're gonna find it. You do all the same steps, sometimes different things, but we get to a point where I'm like, I don't have any tools left. So each time I just kept adding a tool. So Shoemaker, and then I found that Shoemaker didn't address everything, that didn't take care of everything. So then I had been introduced to Dr. Nathan. I had heard about his book Toxic and had read it and resonated with that. So I jumped in and joined his fellowship where we meet once a month and talk about cases. And I was introduced to Dr. Krista and started spending time with her. And obviously, just added on. And I said I would never, ever do any Lyme treatment. But being a mold specialist in Wisconsin with the gene that conveys, long Lyme disease, people would come to me and they wouldn't get all the way well. I'd treat molds and I'd say, no Lyme, no Lyme. All of our Lyme doctors in Wisconsin are, I don't want to say elderly, but they are now retired. So, as it happens with Lyme literate doctors, the next generation has to kind of step up. So that's when I reached out and did ILADS and did a lot of Dr. Horowitz's training to add that in. So it's just one after another. And obviously now with these cool new toys in my toolbox with EBOO and TPE, another whole, thing. It's almost like Pandora's box, right? You open a door and 5 new things pop up.
So do you think that your mom's autoimmunity was the result of the surgical procedure, then letting some of that impact of mold impact her system? Or do you think there was also a foreign body component from the implant where she also had essentially breast implant illness?
Yes, she definitely had breast implants. So I think just like you said, I always say genes load the gun, but the environment pulls the trigger because she didn't have BRCA, so she didn't have the genetic mutation. I believe that gene associated cancers are about 3%. Like it's all environment, it's all these toxic chemicals, all these conveniences of living in our modern world. I knew about hormones and staying young even when I was a conventional doctor, right? I believe that the reason Richard Gere looks like Richard Gere and the Golden Girls look like the Golden Girls is because Richard Gere, he makes testosterone his whole life, whereas women stop, right? We decrease because we don't need to make babies any longer. So I knew about hormones. So my mom was on hormones, unfortunately, horse urine hormones because I didn't know any better back then.
Premarin, yeah.
Yeah, she was on Premarin for years, right? I knew super young. My mom was up until she got breast cancer, she was still running marathons, super active, not on any medications, found the breast cancer, and like you said, had the double mastectomy, put the implants in, and her body immediately reacted. She ended up having over 13 surgeries just to get her body okay with the implants. Now, again, if I were in my spot now, when it started to react, I would be like, get them out. Well, I probably wouldn't have had them put in the first place, right? But she had 13 surgeries just to allow her body to be okay with the implants. Big red flag, right? I mean, we were on a world cruise, the last surgery she had, and she had to fly home from Iceland because her body was just reacting. It was just this big red mass. Again, knowing what I know now, I would have been like, take it out and keep it out, right? So body finally got used to it. And then suddenly, my mom, who had absolutely normal cholesterol, suddenly had lipids over 300, right? Cholesterol is an acute phase reactant. It was telling us that her body was upset. Her doctor wanted to put her on a statin. So, of course, that put her on a statin. She started to react. And what we found was she was on Arimidex just to keep her estrogen low in the face of it. She didn't need chemo or anything like that, but she was on Arimidex, did fine. When she was switched to generic Arimidex as per her insurance, all of a sudden that was like the needle that broke the back. She just one after another is almost like dominoes. She was switched. She suddenly started falling. She'd be walking and her legs would give out. Took her to a rheumatologist, and the rheumatologist called it lupus. She was ANA positive, with greater than 1 to 320 in terms of her profile. I finally, once I'd started doing this work, because that was when I was still in conventional primary care. I finally, when I got into the functional realm, knew about breast implant illness. I treated a bunch of people with breast implant illness. Unfortunately, she went back to her breast surgeon to have them removed. So, capsular and all of those things, I don't know how well she did because even talking to the breast surgeon, she was like, "Oh, that doesn't really matter. That's not a thing. Breast implant illness isn't a thing." So I think it was the breast implant. I think she has genes for autoimmunity. My grandmother had Hashis, my mom has Hashis, but I think it was the stew that we put her in, giving her horse urine hormones that triggered an immune response, putting things into her body that combined with the mold that she'd always been good. Homeostasis is beautiful. If your body is comfortable somewhere and it just floats along, that's amazing. But something, comes and hits, and then those dominoes are out of control. So obviously, unraveling it, you have to do a ton of different things. She did great when we removed the breasts. I got her to stay gluten free. I think she made it about 10 weeks post surgery. Best I'd seen her since the breast cancer. But as we know, foods that are bad for us are addictive, right? So suddenly I noticed that she was getting sandwiches when she was lunching with the ladies, and her symptoms started to crescendo again. And now it's probably we had gotten her down to, dumped her cup so she didn't have a ton of inflammation. She started gradually filling it again. And again, obviously with her home and the toxic load, I'm sure she probably has Lyme and co-infections as well. It was just too much for her system.
So we're going to spend most of our time talking about EBOO and TPE, but I want to get a few more thoughts before we get into that discussion. So you mentioned that genetics load the gun, the environment pulls the trigger. So how much of chronic illness would you say today that you see is environmental toxicant exposure? If we didn't have the toxicity of living in our modern world, would we even be having this conversation about chronic illness? And would you consider toxicity, whether it's environmental or exogenous or maybe even endogenous toxicity from various metabolic processes, would you consider toxicity in general to be at the top of the list of things that contribute to complex chronic conditions?
Completely. I don't think we'd have anything. I think, running from the tiger before we had all these beautiful modern things was our biggest woe. I think if we would have been cavemen and we didn't have all of the new chemicals that our government deem as safe and all of these endocrine disruptors and everything, I just think that, if you have the genes and you keep it out, you live in a beautiful blue zone, you live in the Mediterranean or, places without 5G or any of those sorts of things. I don't think you're ever going to fall ill from a chronic illness.
So there are some differing thoughts or opinions in the various schools around the mold illness arena. So I know you're familiar. You mentioned several of them, Dr. Shoemaker, Dr. Nathan, Dr. Krista. Wondering what your thoughts are on the best way to test the person for the potential of mold and mycotoxin illness. Do you find urine mycotoxin testing helpful? Do you like mycotoxin antibody testing? What are you using to rule in or out mold illness in the person?
So obviously, I was introduced by Dr. Shoemaker, brilliant guy, started the discussion about mold, and I feel like he got good enough results, right? So got to a point, did his cholestyramine, and that was kind of the end of it. But he got great at publishing data, which was fabulous. It's so difficult in this realm to publish because functional medicine, we don't have the backing of big pharma, right? So doing double-blind placebo-controlled studies is almost impossible. It's just we don't have the funding for it. But I felt like I got people, maybe 50 to 60% well. And then I would hit a wall, which is when I would switch. And learning from Dr. Nathan and all of the cares and factors that he's put in, I do a smattering. So at my first intro, my consult, I do a lot of the Ritchie labs. So I will always do things that I find change with what I do, right? So I always say to the patient, I don't need to test you for the gene because if your urine mycotox comes back, I know you have the gene, right? So the gene testing is expensive. So the only time I actually check for the mold gene is if I am a mold expert in legal cases. If I have to be in a legal case, they're going to have the mold genetic test because some insurances pay for it, some don't, and it's very costly, right? It's like $3,000 just for that test. So I usually would do like a VIP, an MSH, a VEGF. I will do a TGF beta, an ADH. So I'll do all the things that cause symptoms in my patients and things that we can look at and say, hey, this is the reason you have shortness of breath when you climb the staircase. So for our viewers, those are some of the Dr. Shoemaker inflammatory markers that he uses. He basically uses a VCS test and those markers just as his basis for a SIRS diagnosis. So I do those. In my intro documentation, I do have a mold and a Lyme questionnaire. So all of my patients, before they come to me, I really already have an idea of what's going on. If I see them in person, which is probably about 10% of my population, we always do a VCS. I have the handheld. My nurse does it before they see me. If I see them virtually, I'll suggest it, but it's not mandatory. So I'll do the blood. I do Shoemaker markers. I do all of the spike protein markers now, things that look at inflammation at the vascular level. That's the combination of spike, mold, Lyme, co-infections that causes inflammation. So my first lab panel, if they have insurance and it'll cover it, is quite extensive. So I'll do that. I always do a mycotoxin. Now, which mycotoxin I do kind of depends on what we're looking at. If I'm thinking and they're thinking they're going to be like a TPE or an EBOO patient, like they've come to me because they hear that I do these modalities, I'll do a vibrant total tox with plastics. So I'll do that because those are the things that before and after a TPE, I can show that it's decreased just with one TPE. So Vibrant is fabulous in terms of their ability to concentrate labs for a good price point. So I'll do that if they're thinking along that way. If they're not, I'll do a real time because real time is the best in the industry in terms of mycotoxin testing in the urine. It's also covered by Medicare. So if I have a patient who's over 65 and on Medicare, more likely to go with the real time because that's going to cut their economical burden. My myco, I really only do if number one, somebody asks for it, right? If somebody says, hey, how can I tell if I'm right now being exposed? Or conversely, if we're on the journey, somebody comes back from Disney World, they took their kids or their grandkids and they say, hey, doc, I really felt like when I went into that Airbnb or that hotel room, it was super musty and I felt like I got a huge mold hit. I will do a my myco lab, Dr. Campbell's testing at that point, because that can tell me acute exposure. Like if we've gotten everything down, they were feeling like $1 million and then they got that hit and they want to know. Because the number one question I get, when did I get this? Did I get this 3 years ago in that terrible rental? Did I get it in childhood? And the one thing we haven't found is the ability to time date a mold exposure. We can say if our body is clear, we can check some things. Like one of the mycotoxins we clear within 2 weeks. So if I want to use a urine test as opposed to a blood test, I could do a mosaic because I can check for mycophenolic acid. That clears really quickly. So I know that if that's present, they have current exposure or have over the last 2 weeks. But that's kind of how I look at it in terms of what they're desiring. Like if they're coming in looking for TPE and EBOO, I will do a total tox. One reason because I'm trying to legitimize some of these things and I'm hoping to publish and show that these modalities work on things that we're trying to get out to reduce our autoimmune burden.
So that sounds and is very comprehensive. For listeners, VCS is the visual contrast sensitivity testing, where in biotoxin illness, you lose the ability to distinguish contrast or shades of gray. And so that can be a screening tool along with some of the tests that Dr. Lyday mentioned, along with Dr. Shoemaker's symptom clusters. That also gives you some insight, the urine mycotoxin testing. I mean, it sounds like you've really pulled the best from many different schools of thoughts, which is great. Let's talk a little bit about binders. So you mentioned cholestyramine in your own health, your headaches. Do you prefer cholestyramine or Welchol? Do you use natural binders? Do you tend to use single ingredients matched to the mycotoxins from their urine? Do you use a broad spectrum binder? What do you find tends to work best for your patients?
I always start with ochratoxin when it comes back because obviously we have the most data in terms of Shoemaker and things like even blue-green algae causing immune system responses. So if ochratoxin is present, and it is because it's found in 96% of water damaged buildings, so I see it basically in all of my moldies, I usually start cholestyramine, but I have a conversation because number one, cholestyramine is not delicious, right? It depends on my audience, right? If I have a little munchkin and they're going to run screaming, I'm not probably going to do it. Obviously with cholestyramine, there are two different forms. There's one with additives that you can get at your local pharmacy, and there's one that doesn't have additives, that you get from a compounding pharmacy. I discuss it. I'm very transparent with my patients. I like to start with cholestyramine if I know that they're going to be compliant. And whether we do it locally or at a compounding pharmacy is really up to them and what they're going to be able to tolerate. I like cholestyramine because it has a greater bind ratio, right? So cholestyramine is going to get majority of the ochratoxin, whereas Welchol, because of its strength of bind, is only about 25% as effective. But what I tell people is nothing's effective if you don't take it. So if I have somebody that's on the spectrum, which mold tends to hit, right? Is it the mold that caused being on the spectrum? Maybe, right? So if they're on the spectrum and they can't tolerate the grit and even putting it in capsules, because you can encapsulate cholestyramine, but If you have the pharmacy do it, it becomes incredibly expensive. If you do it, it's incredibly time consuming and it's a ton of capsules. But if I have somebody that's not going to take cholestyramine, I'm of course going to go to well call, right? But also the well call, the tablets are huge. You have to take you work up to 6 of them a day and they're ginormous. So every person's different. And what I usually tell people, like I had a college sophomore here the other day. She's great at taking cholestyramine over the summer when she doesn't have class, doesn't have school, doesn't have to go to Milwaukee to see her boyfriend. She's terrible about taking it during the school year. So I say, hey, if you throw some well call tablets in your pocket and you get that in the middle of class and you get it in, 25% still better than zero. So I always work with them. And then when it comes to the other binders for the other 4 mycotoxins that cause disease in humans, I like single agents. I tend to agree with Dr. Nathan and Dr. Krista on that. So I like it because number one, I know the dose and I know what the body's going to do. As we know, and I'm sure we'll talk about, most of my patients are incredibly sensitive. I don't get people that are easy. With Dr. Nathan and Dr. Krista not seeing patients anymore, I get all of their really difficult, really sensitive patients. They tend to find me. So I like single ingredients because people that take charcoal might do great, but they might trigger from clay. So when you use a quicksilver that has 4 things in it and I don't know the dose ratio, I don't like that. I'm a control freak. We're all a little bit OCD and type A, right? That's why we're good at this. So I like single ingredients. I like to dose my charcoal. I like to use Takasimi and Integrative Therapeutics because it's made in Green Bay. I use Takasimi most of the time. I like to see where and if they're going to have a Herx. Some people might not Herx on 1 charcoal a day or 250 milligrams, but if we go up to the 1,000 milligrams that I'm shooting for, they might have a horrible Herx. So I like to know exactly where they are because then I can gauge based on that, what does the next step look like for them? Like when I add in Corella, are they going to be able to tolerate 1? Are they going to be able to tolerate 5? It usually is pretty similar. If they can't tolerate 4 charcoal, I'm not going to start them on, 5 Corella at a time. So I like to dose because I'm a control freak and I get more details from that. So that's kind of how I like to do it.
And just to kind of clarify for listeners, when you mentioned the other 4 mycotoxins, that is in reference to real-time labs testing, which groups mycotoxins into 5 different groupings versus if you were doing Vibrant, they're looking at specific mycotoxins. And so you'll see more than 4 potentially other types of mycotoxins. So there is a little bit of a difference in terms of how those 2 labs represent that data. Let's talk a little bit about the external environment, the home, the workplace, other potential external exposure sources. How do you like to test outside of the person? Are you using an ERMI? There's also now kind of a shift towards actinobacteria and endotoxins as causative agents in SIRS. Do you test for those if you're doing an ERMI, for example, and kind of add those on? And how much of a piece of the puzzle do you feel the actinobacteria endotoxin puzzle pieces have been in your clinical experience?
So I typically, this research is so new and always adding and updating, right? So when I first started, I always did a Hurts Me Too. I like the fact that you can do, because I just basically started doing the Vibrant, had always done real time. I like that with a real time and a Hurts Me, you can look because people say, well, is what's in my house in my body, or do I have more in my body that isn't in my home and that sort of thing. So I always did a Hurts Me Too. Sometimes I'll suggest an ERMI. I kind of flow with our indoor environmental professionals, our ICI guys that look at houses and always do the research. I always tell people I know just enough to be dangerous when it comes to home environments. That's one area that I'm planning on learning more about. I have wonderful IEPs that I use with my patients, wonderful people that can come out. So in general, I tell people if it is a space that you want to keep, like say it's a home you own, it's not a rental, it's not a dorm, it's not something, you're thinking about. I usually do an ERMI because you get a wider range and you get all of the really toxic mycotoxins that cause problems even in low doses. If it's somewhere that you're deciding, you want to see if that new home that you're going to put an offer in is going to be okay. It's just based on cost. When we were looking and trying to find office space, we tested over 45 places. So we used a Hertz Me because it's only $155 versus an ERMI that's $290, right? So it all depends on what you're looking for. Now, in terms of actino, that's a big thing in the Shoemaker world right now, an endotoxin. It makes a lot of sense in terms of paper and data. I just haven't seen it play out where it's worth it in every patient every time to look for actino and endotoxins. What I do say is I've seen people that have come to me after they have done the full Shoemaker protocol and they've lived the, actino cleaning, and they themselves have done the scrub downs and the house cleans and all the things that come with actino. I haven't seen that it benefits. So I think it is a big part of it, but I don't know how much getting it out of us is undoing any damage. So what I say is if I get to a certain point and I feel like that might be for that patient, like it's obvious that the endotoxin is causing more neuroinflammation or more fatigue or mast cell activation, I don't think people can live the actino path. I just don't. I don't think it's realistic. I think this journey is so difficult as it is. And then if you add in having to get actino and endotoxins out, I just think there are so many other nuts to crack first. And then if we do all that and there's still things left that I think lead into actino, I think then we go there. But what I will tell you is the patients that I've seen that have done it, it hasn't shifted. So even though I know logically it makes sense that that's causing disruption, I haven't seen that treating it does anything to reverse it, if that makes sense.
No, it makes total sense. And the piece that I'm interested in with the endotoxins is in kind of the Shoemaker realm, they really only give consideration to endotoxins from the external environment. And I wonder how much the LPS or endotoxins that we create in our own microbiome, how much those could also be potential triggers for SIRS that we just really haven't gotten far enough down the path in terms of some of that endotoxin work. It kind of resonates with me that endotoxins could be from outside or from inside.
Exactly.
So another one of the differences between some of the schools of thought is whether or not there is fungal colonization in the sinuses, in the gut, maybe in the lungs, and whether or not antifungal medications are appropriate or not. So wondering if fungal colonization is something that you see in patients. How do you rule that in or out? Is it based on symptoms? Is it based on labs? And then how would you approach treating a patient that was believed to have fungal colonization in terms of their sinuses, their gut, and maybe even more systemically?
If I wasn't already fired from the Shoemaker community, I probably would get fired based on this conversation. I actually saw a patient this morning before our time together, and she's part of a bunch of groups online on Facebook. As you know, when you're trying to heal, you always want people who understand your journey. And she was asking me questions about antifungals, and she said that she's like, I feel like in the Shoemaker group, they feel like it's the Antichrist, the antifungal. I'm like, yeah, that's completely it. It's one of the splitting points, right? And it's very interesting when I try and kind of keep it simple. I'm like, Shoemaker is binders. Neil, Nathan, and Krista are binders and antifungals, and Dr. Campbell is just antifungal, right? When we look at it in a broad general stance. I'm a believer, again, I kind of shine in terms of Dr. Nathan and Dr. Krista. Just because I've been doing this for so long and I've seen so many mold patients. And obviously, I started out with just doing the Shoemaker protocol. That's what I spent probably the first 3 years of my practice doing. And again, I didn't get people all the way well. So to answer your question, when I first started out, I did Marcons on every patient because Shoemaker does. So I would always check for colonization in the sinuses, and I would find a lot of stuff going on there, right? Because our Marcons is going to tell us if they have resistant species. It's going to say what's going on up there. What I found was, again, I have a very acute drive to keep this journey that's already ridiculously expensive as reasonable as we can. So what I found was the $200 Marcons test. I find that even people that don't have Marcons do really well with nasal treatment. So just based on my population, I found I use Beggy spray, and Beggy spray for the population that haven't tried it is a nasal spray that contains 4 ingredients, and it has 2 that are biofilm busters, which literally means it dissolves the outer biofilm that tends to surround the meat in the middle, which is the resistant bacteria and the fungal elements. So I do Bactroban and EDTA. I do an antifungal in the nasal spray. So I use itraconazole, and I use a low dose of gentamicin for the resistant bacteria. And I use that across the board because what I have seen is that if people are moldies, that even if they don't have symptoms in their sinuses, that treating this changes things. Like people will come back and say, I always say, just gamble with me, right? The Beggy spray from my compounding pharmacy is about $35. I'm like, let's gamble with $35 plus shipping, right? Because if you do that for 3 months, I find that people didn't even know that they weren't sleeping because they couldn't breathe through their nose. And they never attributed it to anything because it had been going on for so long that that's just how I am, right? So I find that the treatment, because it's usually 3 to 6 months, as long as we're out of mold exposure, I found that the treatment was cheaper than testing. Now, some people that are, I have some people that still come to me that want strict Shoemaker. The thing that's different about functional medicine is, even though I've done this a lot, you are your body. You know exactly what's going on. And most of my patients are the best judge of what's happening at the cellular level. And they can tell me, right? So if they come in and just want Shoemaker, I'll stick with strict Shoemaker. I'll test and everything. But in general, I know in myself, when I started my mold journey and I started the cholestyramine and I did the nasal sprays, I had asthma, I had outdoor allergies. I was on 4 different prescriptions for asthma and allergies. Within 3 months of being on the nasal spray, I've never had a seasonal allergy, and I've never had anything in terms of a lung, like a bronchitis or a lung infection, or I haven't used a puffer since I started the protocol. So, there are downstream effects that some people don't even realize. So I definitely do that. When it comes to fungal stuff in other parts, right, in the gut, what I find is people that have pretty significant leaky gut and significant food sensitivities, things that don't bounce back when we do binders, I find that they do need antifungals. And what I will tell you is I generally start out with a binder. My usual second step, depending on their feel, and obviously I have intuition and know what their body is going to tolerate. My next step is usually adding in an antifungal, because I don't find, we can do a fungal nasal culture. Obviously, we can do a GI map. We can do a oat test, right, and look for arabinose and tartaric acid and citramalic acid. Those are all markers on an oat test that point towards fungal colonization. But what I really find, again, is the cost of those. Now, granted, downstream, if they come back and they say, gosh, I'm still having gut stuff, I don't find like we can even look at the gut until we get rid of the mycotoxins that are causing the leaky gut and causing things. So I would rather try and start an antifungal and see if things, naturally evolve and improve. And then if we need to, do other testing. But I do it just based on intuition and what it seems like. Obviously, on the urine test, if they have gliotoxin, that also leans more towards colonization, is what we found just based in the data. Obviously, gliotoxin is a water damage building mycotoxin, but it also, if they have high levels on that, that's going to point to systemic colonization.
And do you tend to use itraconazole, voriconazole? Like, what's your favorite tool? Or are you using natural herbal botanicals?
I haven't found the natural botanicals are strong enough, especially if it's somebody that's had a huge history and I think they're super colonized. I use both, especially after our delightful TFIM this past April. I was using itraconazole, obviously with protecting the liver because itraconazole it can be very hard on the liver, especially if you're on it for a long period of time. What I also found was I don't like to use itraconazole if people are still in mold, right? Unfortunately, in the Shoemaker community, they won't even treat you until you have proof that you're out of mold. I unfortunately live in the real world, so I know that, if I tell a family of 6 that's coming to see me that they have to move, give up all of their porous items before they start treatment, it's just as much as I wish that we all had the funds and the ability to do that, it's just not real. So I do treat people where they are, and I give them the caveat that if they are exposed, I can't get them to heal 100%. We can get improvement and we can get them better, but you won't get all the way to heal as long as you're exposed. So if they're in mold, or conversely, if dietary compliance is tricky, I'm less likely to use itraconazole because itraconazole, by its mechanism of action, it is fungostatic, which means it stops the division of the water damage fungus and candida. It doesn't kill it, whereas nystatin is fungicidal. So I'm going to tend to, if people still have exposure or they're eating Twix with each meal, I'm going to tend to use nystatin versus itraconazole. The reason being is nystatin, and you might have seen patients like this. I'm sure most people have heard of it. You have people that come to you that say they have candida and they've been on nystatin for 12 years. And they're like, oh no, my candida is well controlled just as long as I take my nystatin every day. Well, obviously these people are not, they're moldies, right? Because if we're not getting to the root cause, you're obviously going to have flares when you stop your nystatin. But you can be on nystatin long term and you don't have to worry about liver involvement and you don't have to worry about it growing immune. We worry about antibiotic resistance. Antifungal resistance is a much bigger deal because we only have 5, really that work in this regard. I also use amphotericin. It was funny because I used to be a hospitalist, but amphotericin in the hospital, we call it amphoterrible because if we put it in via IV, it destroys the kidneys. So we only use that as like last resort, right? But if we use it in the gut, it's incredible because much like the other, you don't have to be as concerned about liver involvement. So I will use that, but I will also say that unfortunately, because we have to compound that, amphotericin has a higher price point. So I usually start with either itraconazole or nystatin, depending on the environment of my patient, and then I'll add in the other one. Of course, if they're still in it, I'll hold on the itraconazole until we can make a lifestyle change in terms of exposure, as well as in terms of high carb diets, because I don't want to keep feeding what we're trying to kill off.
So we're going to start moving soon into our EBOO conversation, but I think this question fits here since we're talking about fungal colonization. Do you think that EBOO has any role in terms of antimicrobial, antifungal effects for that fungal colonization? Or since it's really delivering that ozone and oxygen through the bloodstream, do we still need these other tools to get into the sinuses, to get into the gut as well?
I think we still need the other tools because much like any kind of colonization, the biofilms are a real thing. And as much as EBOO is great for whatever it touches, first of all, it's only touching 2 liters of your blood. But second of all, it's not going to get into the deep crevices, up in your sinuses. It's not going to get deep into your gut. So I think you always still need, I would never say, yeah, I'm going to cure your colonization with EBOO. It's good. It's a fabulous modality, but I still use it with binders and nasal spray and antifungals for sure.
Do you see in your chronic Lyme disease patients that they generally tend to have a mold and mycotoxin component as well? And when someone has both, is treating mold enough? In other words, does the Borrelia, Bartonella, and Babesia then essentially become a non-issue? Or do you find that we do need to treat both the mold and the Lyme complex?
I usually always start with mold because of genetic predisposition. Obviously, and I'm in Wisconsin, where 90% of people have exposure. They generally need to get their immune system back online. And I find that mold is the biggest barrier to that. So I would say in my practice, 90% of people just need mold treatment. And then it's like once the immune system comes back online, it makes Lyme and co-infections what they should be, kind of a one and done, like it is for people without the genetic susceptibility. So the only time I start with Lyme is if somebody comes to me with acute Lyme, like they come in and say, hey, doc, I had a tick bite and I have a bullseye. Or conversely, if it's something where it sounds so much like Bartonella or co-infections that I feel like, we can't get past that, or they're in an incredibly moldy environment and I'm not going to be able to get them out. Sometimes I will treat chronic Lyme first just because it's so exhausting. Sometimes we just need that boost to be able to move forward.
So what I'm hearing is once you've addressed the mold, then you may still need to do something to treat Lyme and co-infections, but it's generally shorter duration and you don't have to be as aggressive with the interventions that you're potentially using.
Exactly.
How important is working on the limbic system, the vagus nerve, the autonomic nervous system to kind of set the stage for healing? Is that something that you recommend your patients implement as a practice in terms of limbic and vagal realms? And how important are those tools as a foundation for reducing sensitivity to the environment, but also to the treatments potentially, so that your toolbox can expand and then ultimately maximizing their healing potential?
I used to not recommend it at the first visit because I feel like there's so much medical PTSD. People come to me and they feel like they haven't been heard, they haven't been understood. And if the first thing I say is, I think this is all in your brain, I don't think that starts a good communication. But after having so many sensitive patients, because like I said, I've inherited, just like Dr. Nathan said, like as you get further out in this, you get less and less of easy patients and definitely more intricate. So the more sensitive a patient is, if somebody comes in and they tell me at the first visit that they can only eat fresh fish and Evian water, vagal right away. I'm going to say that they have to start that while we're running labs because at that point, their cell danger response won't allow healing unless we calm that down. I would say probably in 50% of my new patients, I suggest vagal reprogramming. Could be a variety of different things, whether it's Gupta or Primal Trust, or if it's just a vagal stimulator, right? If they don't have the brain space right then because they're so moldy that they can't even sit down and do a Gupta or a meditation. But I think it's a huge part. Most people, after, 2 or 3 visits, if we're not seeing the response or they're reacting to everything, and like you said, I'm going to go into bigger things, I'm definitely going to have them start. And it's going to be mandatory, where I say, if you're not doing something to reprogram your vagal system, I'm not going to be able to take you on something that could potentially cause a bigger herx or a bigger cell danger response that might hurt you.
So now we're going to get into the main focus of our conversation today, which is the 2 emerging tools that we talked about, EBOO and TPE. I know that there's potentially some overlap between what these tools do in the body, but is it reasonable at a high level to think of EBOO as more microbial support and TPE as more detoxification support?
That is totally how I explain it. EBOO is going to hypercharge. It's going to help the mitochondria. TPE is going to remove things that are pissing off the immune system. So that's spot on.
So, where in a treatment protocol, then, in terms of the overall timeline, when someone's recovering from a complex chronic condition, might EBOO or TPE make sense? Are they things that you use later in a protocol? Would you use them early on? Would you, if someone was still in mold, does it make sense to do EBOO or TPE, or should they take that money and remediate their house? Like, where do these fit into the sadly often longer timeline in this chronic illness recovery?
It kind of depends on where they come from. Examples are I have somebody right now who has a really, really advanced autoimmune disease and has been given basically, they've outlived their timeline. They were given 2 years to live and they're at 2.5, right? So, someone like that, I started TPE right away. But in general, these are very expensive and they work incredible. But if we keep upsetting everything, by exposure to mold, by exposure to toxins, it might give you enough oomph to be able to do more, but it's not gonna sustain the same as if you've purified your body, purified your environment, and are farther along. So, like you say, do I say a $7,000 TPE before $7,000 to remediate your home? Absolutely not. I want you in a clean environment. And like I said, I'm cognizant and transparent about the cost of this because I've been through it. So I understand that all of this is expense out of your pocket. So I'm never going to suggest something that your body won't hold on to. So usually it like you said, it's a finishing, right? It's like the frosting on the cake. Now that being said, I use nasal ozone all the time. If I have somebody who's concerned about using baggy spray and they're here, nasal ozone is cheap, it's easy. Same with rectal ozone. All these modalities are very reasonable, like less than $100. Joint injections with ozone, if they're having a hard time getting movement and we want to circulate the lymphatic tissue, I'm going to do a joint injection for less than $100 and reserve things like EBOO and TPE for later on.
You mentioned autoimmunity. Where do EBOO and TPE fit in with your autoimmune patients? Do you see autoimmunity as more infection driven? Do you see it as more toxicant or toxin driven? If someone then is using EBOO or TPE, are you seeing some lessening or resolution of their autoimmunity? Are you seeing them essentially being immune modulatory in some way where we're using EBOO or TPE to kind of calm down that trigger happy or hyper vigilant immune response?
I think EBOO and TPE, the best places for people with autoimmunity, right? It's best, it's the easiest way to get a bunch of inappropriate cytokines and proteins and things out of the body so that their poor immune system can kind of get back to self-regulating. So I love them. Where in the journey kind of depends on how much funds they have, as well as where we are on, pulling things out with mold. What I find is it kind of, when we look at the inflammation in the cup analogy, it ridiculously reduces it. So I find like it's amazing. Now, obviously, I do other things, right? I'm not going to just say TPE and EBOO, even if they're coming to me for that. I'm still going to talk about things like LDN to calm down the immune response. I'm going to talk about things like LDI. I always want people to resolve and get better on the lower cost because I know that you have these genes and we live in this toxic environment forever. So this is a marathon and not a sprint.
So I want to take just a very quick diversion into the autoimmune realm. Hashimoto's you've mentioned, that is autoimmune. I tend to think of exploring Borrelia, EBV, heavy metals, mold, all of those things. But I'm wondering, how often do you see a Hashimoto's patient that does not have a predisposition to mold and does not have mold illness or an environmental exposure that's driving that condition? And once you address that mold contributor, do you see normalization of TPO and thyroglobulin antibodies in those patients?
I didn't realize this, but I'm listed as an expert in the Hashi's world, and the reason is obviously endocrine. They tell people you have Hashi's, come back to see me when you've eaten your thyroid completely. I see resolution of Hashimoto's antibodies all the time. I've never seen a Hashi patient that isn't a moldy. So when you address that, that's where you get to root cause, you know? So what I would say is I see it all the time. And if you don't address the mold, endocrine's right. You're going to have Hashis. So I just, every Hashis patient I've ever seen has mold.
I think that's the sound bite for this episode that people need to hear. Are you currently, when we're thinking about EBOO and TPE, are most of the people that are drawn to do these, are they chronic illness patients or are they biohackers and anti-aging type people? Like who's in your population?
I have both. What I will tell you is the anti-aging are a lot easier because in the anti-aging community, really they're healthy. You know, they just want to live to be 180, like Dave Asprey, right? They're doing this so that that toxic world doesn't affect them. And we don't have to do as much in terms of worrying about sensitization and some of the things we'll talk about in terms of how the body's going to react. Because even though all these modalities are great for you, it doesn't mean that your body isn't going to give us a little pushback because it's very happy in the defective stew that it's living in, right? So I would say we probably have 60-40 in terms of 60% being autoimmune and about 40% being like the biohacker anti-aging.
So let's talk now about EBOO or extracorporeal blood oxygenation and ozonation. I see some call it EBOO. I see some call it EBO2. I've seen EBOO-F. I mean, there's so many different abbreviations. So talk to us about the potential benefits of EBOO, when you might use it, and what you're seeing clinically in those patients who have done it.
I love EBOO. We've known about the benefits of ozone for ages, right? A lot of us have done 10 pass ozone that deal with mold and Lyme. A lot of us have done just regular MAH, and it's incredible, but it's limited to the amount of ozone that we can get touching our blood cells, right? Because as we indicated earlier, this isn't going deep there, you know, other than hyperpowering our mitochondria, there's only so much it can do. So the beauty of this machine is it takes 2 liters of your blood, which is somewhere between a third and a half of your blood supply, and it runs it through a machine where that blood is introduced to ozone. Now, ozone is relatively unstable, which is why it works so well, because once it hits something, it's going to turn into oxygen, right? So both oxygen and ozone do really well at treating. They do well at treating viruses. That's what it's especially good with is viral modulation. Does really well with bacteria. Bacteria don't like being hyperoxygenated. Doesn't do as well with some of the other things in terms of removal, although it does remove things, and we'll talk a little bit later about how it does that. But it's one of those things where it is incredible and it works really well because the price point is not as high as TPE. Now, obviously, they're great together because obviously using TPE and then EBOO afterwards, you're going to get a better response because we're taking the garbage out and then we're hyperoxygenating what's left. So EBOO it's going to treat, you know, a third to a half of your blood in terms of what's in there. So bacteria, you know, parasites, viruses that it comes in contact with, incredible.
So that was actually going to be my next question, and that was, is the oxygenation portion of EBOO, is that from the introduction of the ozone then turning into O2 and a free radical, or is there also oxygen or O2 that is independently delivered from the O3?
Yes, there is both. So it is oxygen and ozone. Ozone is superior in terms of interaction with viruses and bacteria just because it's better at killing. And oxygen, obviously, better for mitochondrial support and everything, but it is both. And obviously, some machines like ours also has UV light that's being introduced to that blood as well. So it's both oxygen and ozone, and they're both important for different reasons.
And when we're looking at the amount of ozone that's delivered, how might that compare to MAH or major autohemotherapy or 10 pass, for example?
I think that EBOO, in terms of the price point, is far superior because we all know how 10 pass is ridiculously expensive. MAH is pulling about 60 milliliters of your blood and you're ozonating and putting it back. 10 pass is 10 times that at a high price point. EBOO is less than a 10 pass, I think, depending on what people are charging, and you're doing 2+ liters of blood. So I think for the price point and what it's targeting, you're getting a much better return on investment in terms of EBOO.
And when you say EBOO is less than 10 pass, you're talking about cost, not the ozone amount.
Yes, because depending on where you go, here it's 1,500. I've heard 10 pass being much more expensive than that. So I just think, yes, less in terms of cost.
So you're paying more and getting less, it sounds like. So talk to us now a little bit about the EBOO process itself. Are there things we need to do before doing EBOO? What's the patient experience? Talk to us about the venous access, and is that easy? Is it sometimes difficult? How much of the blood, you mentioned about 2 liters, I think, goes through the process when we're doing EBOO? How long is an EBOO session? And then are there things we need to do after the session to support the patient?
So EBOO, one of the things that's super important is you do have good vascular access. We get patients from all over the country, actually all over the world. And at that first consult, I'll evaluate how is their vascularity. Can we get 2 points? Because what we're doing is one access point is going to be blood coming out, going through the machine. The other vascular access point is the blood returning after it's been cleaned. Now you can do it on one arm, but you need 2 different vessels, right? So you're pulling and then putting back. So if I see somebody, they've been through chemotherapy, they have a hard time, they tell me things like, I can never get blood, right? Like when I go for labs, they always have a hard time. I will start them on a venous protocol. And this is true for both EBOO and TPE. So I will start them on a bunch of herbs and things that will help make venous access more easily accessible. There are some people where we have to think about a port, and if they are unwell enough and really want to do TPE and or EBOO, sometimes we need port access just because it's not a possibility. I know for my first EBOO, my first couple of EBOOs, because I hadn't started my venous protocol yet. I always have grate on my left arm. They couldn't find anything but my foot, right? So now that's not recommended. That's definitely not what we're taught. But for me, that was all I had at the time. As I've progressed and my vascularity has gotten improved, unfortunately, I have a lot of spike protein from mandatory vaccination. But as that has improved over time, they can do it on both my arms now. I had actually thought about getting a port. I don't need to. The journey takes about an hour and a half. I usually tell people to plan for 2 hours because we have to get access. We have to get it going. And the total duration of ozone and UV light is 50 minutes for a full treatment. Now, sometimes if I have a very sensitive patient and I'm worried about after and how their body will tolerate it in terms of potential hercs and other things, we might not go for 50 minutes. If I have a sensitive patient, we might go for a full treatment really is considered anything over about 25 to 30 minutes. Some people would rather err on the side of caution than have a huge herx and feel like a bag of poop for the next week after. To answer your question about what we do after, I have found that in my sensitive people, I usually use a binder. I'll usually tell them to take a dose of charcoal after because that'll minimize any potential for Herxheimer reactions from all the stuff we're killing. We obviously have them hyper push fluids, make sure they get their water in. And usually, I think we've only had 1 or 2 that have said that they've noticed anything after. Sometimes people feel fatigued, right after the procedure. Most people the next day feel incredible.
And is EBOO one and done? Do people generally do a series? How far apart would they potentially be?
I usually start with 3. I say that because it's only 2 liters, I want to treat all of your blood and I want to do it in quick succession. So I normally say weekly for 3, and then we figure out how you're doing. And it really depends on exposure. It depends on how toxic you are. It's one of those things that I don't ever see myself not doing on maybe a monthly or depending on how far you have to travel, maybe 3 times a year, because it's always good to get that yuck out and see how you do in the long term.
So let's say we do an EBOO and there is this potential for a Herxheimer reaction from the organisms that are impacted by the ozone. There is also the mitochondrial increase from doing EBOO as well, which could potentially have some effect on our ability to better detoxify. Maybe there's some toxicity. We'll talk more about this. Maybe there's some toxicity that is filtered out in this process as well. But wondering then if you see people that maybe do have a little bit of a flare, a mast cell issue, more inflammation, essentially thinking that if you clean the blood, then you have this kind of osmotic gradient or equilibrium, or some call it Le Chatelier's principle, where essentially then things that are in tissues start to be released. And that's maybe more of a toxin concept than so much of a microbial concept. But if we do EBOO, are we then potentially releasing things kind of in layers? That's part of the reason that we then want to do another session later. Talk to us about that a bit.
I find that there's probably the reason that they did it, so it was 2 liters of blood, is kind of the sweet spot. We have played around, myself, my husband, my staff, in doing a longer session, because 50 minutes is not, written in stone. Obviously, the longer you do, the more blood you're doing. So you can potentially stay on there for 3 hours and do a whole, body volume in one time. I think that that's the sweet spot, because I think diffusion is big. I think we want to treat what's active in the blood, treat that, give a binder so that if things, are broken apart, like you say, we hit a bunch of viruses, we hit a bunch of things. Our body likes to do things in bite-sized pieces, and the sicker you are, the smaller the bite. So I would rather do it and then have them come back than do it all at once. Now, sometimes I have people that are coming in and they're staying for a week from out of country or out of state, and they want to stack things. And I'm fine with that. I'm just transparent that they might have a bit of a more fatigue, more brain fog, more, symptoms, more Herx-like symptoms or intensification because of that, because we're treating more. Now, in the end, they might do better, right? If I stack a TPE with an EBOO and then a stem cell, they might do better when they go home. But the actual journey, the actual time when they're here with us might be a little more fatiguing.
I'm thinking then that this idea of doing something that's filtering or cleaning the blood that might then lead to tissue release elsewhere, that those toxins then are kind of coming back into the blood, sounds like that's potentially more relevant in the TPE conversation than it is in the EBOO conversation.
Yes, exactly. So that's what I find with TPE is that we treat and then I like a period of time so that the body can release more. I'm playing around with doing 2 TPEs a week for people with pretty extensive autoimmune, and doing a few weeks of that, and then allowing the body to recover for a month before we decide what frequency we're going to do going forward. But yes, I think that's more plausible in the TPE than it is in EBOO.
We talked that at a very high level, EBOO was more focused on the microbial piece, but there is some filtration happening as well. So talk to us a little about the kind of filter that's used. Do we think it has any impact on mycotoxins, pesticides, chemicals, metals? We know that it has some impact on pathogens. My understanding is it may have some impact on immune complexes or cytokines or maybe cholesterol or fibrin, other metabolic wastes. So talk to us a little bit about what you're seeing EBOO may have the ability to filter. And then because you also mentioned spike proteins, like is EBOO potentially helping to reduce spike proteins in the body, or is thinking of it as a filtration tool really kind of the wrong way to frame it?
When I think of the two, I obviously think of TPE as being more of a filtration. But as you said, It is a dialysis filter. That's what's in there where the blood and the ozone meet. So it's going to clear small and mid-sized molecules. That's just how it is, right? Now, when we actually there have been people that have looked into what's in the foam because foam is something that changes from person to person and from procedure to procedure. I've had EBOOs where my cup is overflowed, literally, like the foam container into a garbage can, and I've had procedures that I've had very little. And it hasn't necessarily been the more I've done, the less foam I've had. So we don't have any proof of having mycotoxins or pesticides or spike protein, but it's possible. It's hard to say, right? It is a semi-permeable membrane. It is going to clear toxins. When I look at it, if I'm looking for that specifically and I have a patient that wants that, I'm going to lean towards TPE because I'm sure of that. But I'm sure EBOO does it. And I'm sure that the more data we get in terms of the particulate that's coming out, we are going to see that, especially the small and the medium size things that can't get through.
So one of the things that I understand it potentially can help to reduce is fibrin. And we see all these videos online where people are pulling clots out of a line when they're doing an EBOO session. We know now in the COVID era that there's more coagulation, more microclotting, more clotting issues. So wondering if EBOO potentially helps to minimize that viscous or thick blood, or maybe what some call rouleau. And if EBOO does have the potential to improve our blood viscosity or coagulation or fibrin buildup, do we still need to longer term be on things like Baluch or fibrinolytics or anticoagulants or things of that nature?
I think that fibrin is definitely a part of that. I have not seen, I've seen a lot of the sensational videos where they're pulling long, things. We haven't had the propensity, the amount that other people have shown. I've seen a couple people, including my husband, on his first treatment where he clogged the machine with his viscosity. I know it's working. And even if it's not necessarily directly pulling fibrin, I think it is. But if it's not necessarily doing it, I think that the ozone and the oxygen are doing it. So I think that it is great for that. I kind of look at it because it's increasing our oxygenation, decreasing our fibrin. It's a reset, but I wouldn't necessarily see it as a standalone solution for spike protein, for, inflammatory modulators, for, cytokines.
So you mentioned that EBOO seems to be good for bacteria, for viruses, maybe also in part because of the ultraviolet that's a component of that process. What are the organisms that you feel like it's been most helpful for? Are there some where you feel like, yeah, EBOO is not going to be my go-to? If we're thinking about, let's say, someone with Bartonella or Babesia, is EBOO potentially helpful? We know those are very difficult to treat for people. So where do you see EBOO moving the needle, and where do you maybe think, I'm going to use something else in my toolbox?
So I think when I'm looking at viruses and bacteria, that's where I'm thinking EBOO because of viruses, both in terms of ozonation and the UV. They've shown UV really good benefit in terms of viral disactivation. So I think you're going to get the biggest direct benefit. I think if you have an active viral illness, or like you say, we have a reactivation like EBV or things like that, I think you're going to have the biggest reset in terms of that. Also, bacteria, it's very bactericidal. Now, the problem with that is it's not going to get in a biofilm, right? So a lot of the times, kind of to cycle back, what I'll do is I'll treat for those things, biofilms, and I'll treat with, nattokinase and all of that, trying to dissolve so that when they get the EBOO, they get the biggest bang for their buck. In terms of fungi and parasites, fungi, I think it's indirect. I don't think it helps with colonization. I think it's more supportive, but not curative in terms of that. And with parasites, symptom relief, it's not getting intracellular, right? So it's going to help with anything that's there. But I don't think, like I said, I think it's indirect in terms of improvement.
Yeah, that makes sense because I think, a lot of the parasites that are GI parasites as well aren't necessarily going to be in the blood, even though we know we have parasites like Babesia that potentially are, but it sounds like even then it's not necessarily going to have a strong effect on intracellular parasites.
Exactly.
So let's start our TPE or therapeutic plasma exchange conversation by kind of educating listeners on what plasma is as a blood component and why we're focusing on plasma, thus plasmapheresis. What is it about the plasma that makes it relevant to the conversation about removal of those things that are health negating and removal of environmental toxicants and toxins from the body?
So plasma is the fluid, right? It has dissolved proteins, which is where a lot of our bad stuff hides. It hides in conjunction with our proteins. So whether it be cytokines, whether it be inflammatory proteins, all of that tends to be dissolved into our plasma. And what is not dissolved into our plasma in the current moment, when we remove the toxic load, will then diffuse out because our body is magical in terms of what it can do if it's not overloaded. So that's why we do plasma, and that's why we target that, because that's something where the majority of the inflammatory stuff likes to hang out.
So, terminology wise, we hear apheresis, which I first heard in the Dr. Klinghardt realm. That really is a Greek word that means to remove. And so there was the work of Dr. Straube in Germany, which later became known as INUS or INUS pheresis. And I know that there are places in the US that offer apheresis that has a focus on filtration more so than conventional plasmapheresis. But my understanding is the filters that we can use in the US are not the same as the filters maybe they're using with inus pheresis, for example. So, how does the filtration compare in terms of what we can do here versus what we can do outside of the US? And then, building just on the topic of plasmapheresis, I think what we commonly think about with plasmapheresis, at least in the limited knowledge I have of it, is kind of in the PANS and PANDAS realm, right? Where kids are going in, maybe people with neurological or autoimmune conditions, and having plasmapheresis. But that's different than a TPE or kind of therapeutic total plasma exchange, as I understand. There's a smaller amount of plasma being removed. And so I'm interested too in that more conventional plasmapheresis. Do we even have to consider replacing anything, or is the volume so low that we don't really need to replace what was removed? Talk to us a little bit about plasmapheresis, apheresis. What are some of these types of aphereses that are out there? I wasn't sure if it was apheresi, but it is, I believe, aphereses.
I think you're right. I want it to be apheresis, but I think you're right. I think it's apheresis. So, like you said, Scott, obviously apheresis is any extracorporeal procedure that removes some sort of blood component, right? So, obviously, plasmapheresis, plasma being the first part of it, removes plasma. You can do a leukapheresis, which is white blood cells. You can do a erythrocytopresis, which means red blood cells. You can do a platelet pheresis, which is platelets, and you can do a lipoprotein pheresis, which is LDL cholesterol. Like you said, the difference here versus the UK does inus pheresis, and so I apologize for our audience if I'm pronouncing it all wrong. That is what's done outside of the US and the UK. There are, it's almost like standalone places where, just like IV clinics, you can walk in and get inus pheresis. I'm really looking forward to it. We're working with the FDA. I'm hoping we're going to be one of the first sites where we're running experimental inus pheresis. We're hoping to have that mid-year next year. The difference being the inus pheresis, like you already kind of nodded to, is it has a multi-step filtration. So we're sure that it removes immune complexes, it removes fibrin, it removes toxins, and it removes pollutants. The difference being is, especially in our very sensitive patients, inus pheresis is more of a cleaning. So it actually takes things and it adds nothing back. Like, it basically cleans you up, like truly an oil an oil change other than you're not getting new oil back, right? So it cleans and replaces your own plasma back. When we talk about a TPE versus just plasmapheresis in the kid community, when we're doing pans and pandas, and or if they're doing it in the ER when somebody comes in an autoimmune failure, you're taking out small volumes, and like you said, you don't have to replace with plasma or albumin or all of that because it's such a small volume. When we do a TPE, we can decide how much plasma we're going to take. So when we talk in terms of that, it can be like a 1 or a 1.5. That basically means 1 means total volume, right? We're doing a whole exchange. I'm taking all of the plasma in your body and I'm replacing it with another fluid. Now, we use albumin because studies have shown that replacing with fresh frozen plasma actually is not good for us. So we use albumin. And you can do a 1.5. 1.5 means you're doing it 1.5 times. Now, we don't do that. In fact, we even start a little bit lower. A lot of times, our first time, we're going to do a 0.6 or a 0.7. The reason being is we want to make sure body tolerance and that the body is going to be okay with it and adjust well to removing, because as we know, even though we're incredibly toxic with autoimmunity, our body's used to it and it almost likes being toxic. So when we reduce that toxic load very significantly, very quickly, we're more likely to have symptoms as a result afterwards.
So let's now talk about the experience then of TPE. Are there things we want to do before in preparation? What is that experience? Like what's happening? The blood's being removed, it's being separated in the machine. I guess then it's the non-plasma is being returned. Is there a filter that's involved in TPE, or is the filtration essentially from the removal of the plasma? Then are there any things that you would do after a TPE session? How long is that session, and how many would one generally do over a particular period of time?
So first of all, there's no filter in therapeutic plasma exchange. It's basically just removing the plasma that is the natural filtration. And it's a bulk removal, right? You're taking out all of the plasma. The procedure itself ranges in duration. I've done it. So have I had three? I've had three TPEs. My first one, as I said, we had to use my foot. So it was not ideal in terms of the patency of the vessel, at least for return. My first TPE took about 4.5 hours. Now that's a long procedure. If you have amazing vessels like my husband that are big tubes, typically about an hour and a half to 2 hours is a good procedure in terms of doing a whole body filtration. I do things ahead because number one, I want it to be successful for the person. I want to be able to get vascular access. I want them to be able to tolerate it. I want them to feel good afterwards. Now, how often we do it basically depends. If I have somebody who's on borrowed time and I know that cytokines, inflammatory proteins, all of this are a big part of their journey, I'm going to have them come in twice a week for a few weeks. And that probably is 3 weeks. I like twice a week for 3 weeks. And then I like to readdress. I would probably redo my total toxin with plastics at that point and see what that looked like, or whatever inflammatory markers I'm tracking, whether it be spike protein level, whether it be fibrin, whether it be wherever we're looking. I haven't started mapping the Shoemaker inflammatory markers yet, but that's on the docket. As we know, it's very costly, and if people don't have coverage for blood work, it's difficult. But typically, that's what I would do if it's somebody who's in for anti-aging, right? Like our superhumans, they want to live to be 180. I usually will recommend monthly. I like 5 to 6 is my number. Now, obviously, this is all cost driven, right? In the dementia community, they have shown that doing 6 to 12 really reduces the amount of amyloid and the amount of mental dysfunction. And obviously, we know that being in a nursing home in a memory care unit, you're looking at like 18,000 a month. So TPE ends up, even if you have to do it twice a week for a couple months, it ends up being cheaper than long-term care. So it kind of depends on the patient, the budget, what we're trying to accomplish, how quickly we're trying to accomplish it, and where we're going. Now, after TPE, and we'll probably talk about this. Now, obviously, when I'm taking plasma, I'm not just taking junk, right? I'm taking other things too, things that are good and that might need to be replaced. So one of the things we do is we always replace things that are likely when they are low to cause problems. Calcium is the biggest, right? Typically, because of the anticoagulant that we use, which is citrate. Citrate tends to selectively bind to calcium and potassium. So I do a specialized mix that's pretty similar to a Myers, which for most of you guys you would know is kind of our intro to IV fluids that has a little bit of everything in it. I also give calcium before the procedure. For my sensitives that might have a reaction to the citrate, part of my vein protocol is I use a natural antihistamine. I use D-Hist by Orthomolecular as part of my vascular protocol. That's going to reduce the overall histaminic portion and render them less likely. I also give an H1 blocker before we start the procedure the morning of, in addition to Tums to replete the calcium so that they feel good during the procedure. And then obviously there's calcium and other things in the bag afterwards to put things back. Some places are doing IVIG and other immunoglobulins after. We haven't. We're relatively new. We've only had our machine since May. It might be something that going forward we look into. It's incredibly expensive. You know that I like instead, and I like doing things like stem cells. If we're going to do an expensive procedure after an expensive procedure, I find I get better results with using stem cells.
So TPE is similar to EBOO in terms of needing 2 points of access. You mentioned that in some cases, someone might have a port, but if you have a port, you still then need one additional point of access, or can a port handle both at the same time?
So if it's me asking the surgeon to put in a port, I'll do a dual access port. If it's somebody that just has a port because they've just come off chemo, which we do have a couple patients or something like that, then yes, if it's just a 1 lumen, then I will need a second access. But if I have somebody, like I have somebody right now that is very incapacitated as a result of spike protein, she lost a great deal of her lung function. We're not sure if she's going to be able to do it with just vascular access. So far, 100% of our patients we've been able to do with peripheral access. We're having somebody start on Monday that we think might need a port. If that's the case, they do have a dual access. It has 2 lumens, so you can take out and put back in the same port.
So you mentioned that it could be all of the plasma in the body that's removed in TPE. And so we have this volume loss that has to be replaced with something that could be plasma, but you mentioned it's more commonly albumin. How does hematocrit come into the conversation? Is that helping you to determine how much albumin to reintroduce into the patient? And then, one of my curiosities around this whole process is albumin is still a human blood product, which would make me a little nervous just knowing what we know about medicine. So is there any risk of acquiring new infections from someone else's albumin? I'm assuming it's probably pooled donors in that albumin source. Do we need to think about spike proteins maybe that could be in the albumin? What are some of the things then that we would do to kind of balance the fluid dynamics when we're removing so much from the body? Do we need to think about electrolytes or things of that nature as well after TPE?
So like you said, the numbers we need going into this is a current CBC, complete blood count, because I need to know where the hematocrit is. Because as you stated, Scott, hematocrit determines the ratio of plasma to our red blood cell count. So the higher the hematocrit, the less plasma that patient has, kind of the more thick their blood is. In addition to that, we need an ideal body weight, because that's going to determine how much of a therapeutic exchange we're going to do. And so basically, as smart as machines are, we kind of type that in and it'll say, okay, you're going to need, somewhere between 2.5 and 4.5 liters of albumin in order to make up for the plasma loss. And of course, that is the two questions that come up probably in 100% of my TPE patients are, is albumin safe and is citrate safe as an anticoagulant? So number one, albumin, like you say, is a human blood product. It is pooled. Now, we're guessing and studies have shown that it is very unlikely that spike protein transmission through albumin is happening. Same with viruses and proteins because of the way that they treat the albumin. Viral inactivation and protein fractionation is a thing. So that is not a significant concern. They have never isolated spike protein from albumin. I understand that makes sense, that people are concerned about it. Yet there's no way they definitely have not said, we only take this from non-vaccinated individuals. So I understand that that's a concern. We just haven't seen it. And like I said, the two electrolytes that we're most concerned with are calcium and potassium. What I will tell you is what I've heard from people that have gone to other places. Calcium, because of citrates, removal of calcium, that's the most likely to cause a symptom during the procedure, where people would have muscle cramps or a weird kind of tingle all over their body. That's a citrate reaction, but it's because of a lack of calcium. We haven't seen it because, like I say, in my vascular protocol that I give to people beforehand, we do have a calcium. We also, like I said, give Tums, which sounds silly, but it's an easy bioavailable way to get it in quickly and stop the fact that we're going to be removing calcium and potassium from their system. And like I said, afterwards, we give a 1 liter Myers, not really Myers, but Myers-esque, which basically has anything that we're potentially removing so that we leave them hopefully better than they came in.
An IV Lyday. So what does the color of the plasma tell us about the toxicity of the patient? Is it true that the color visibly changes over time with TPE sessions? My probably first exposure to this was Brian Johnson holding up his, big bag of plasma from doing TPE. So what does the color tell us? And then kind of coming back to the conversation we had in the EBOO portion of our conversation around filtration, sounds like with TPE, we can reduce metals, pesticides, chemicals, plastics, spike proteins, all of these things. What do we think then happens to other storage locations of plastics? Like they're talking now about plastics in the brain, in the testicles, in all these different body places. So do we think that once we remove it from the blood, you even mentioned amyloid, which I tend to think of more in the brain than the blood, though I guess it's in both. But when we remove these things from the blood, do we then think that they are being released from their storage locations in terms of plastics, maybe amyloid, maybe other things, and that we're then able to get more and more of them out with each subsequent session?
Yeah, that was a loaded question. Way to get everything in there, right? So my favorite part is the end when I take a picture of people holding up their plasma that has come out in our garbage bags. So, they say color alone doesn't really equate to toxic load. I think it has a good portion. The most crazy one I've ever seen is somebody who, we've never had this before. We actually had to call for support. His plasma was so full of lipids that it clogged our machine. He had the worst plasma I've ever seen, and he actually is one of our sickest patients that actually being treated right now because of the fact that he's kind of on borrowed time. His plasma in general should be straw colored, and you should be able to see through it. When it becomes milky or you can't see through it anymore, it's a thicker consistency, or when you hold the bag, it's a good portion of it is thick and then the top is a darker color. We know that there are lipids in there. We know that there's, clotting factors, immune complex, cytokines, toxins. what I will tell you in my own journey, because obviously we always experiment on ourselves first. After one TPE, I did a total tox with plastics on myself on 6/24. I did one TPE and then I rechecked it on 8/10, the exact same panel. The first one, I had one mycotoxin and one forever chemical that were in the red in terms of vibrance panel. And I had 14 mycotoxins, environmental chemicals, metals, and plastics in the yellow. On 8/10, I had none in the red, which was after my first. I had 12 in the yellow, but all of in the yellow were down by 40 to 60% from the level that they were at the first total tox. So that's just my panel. I didn't do, and I should have, looking back on it, I did not do I didn't do my spike protein before and after, because that's a big part of my story. And I didn't do any of the Shoemaker inflammatory markers. But just based on that, I know that in that TPE, that it's targeting all of the stuff that nothing else targets. Our forever chemicals, we say they're forever because they are. So the benefit is for that whole volume of plasma that's removed, we got all of that out. And like you elucidated, that then it gives our body the room to allow diffusion to pull from stores, because not everything is floating in our plasma. A lot of our body will sequester it away because it's toxic. So as soon as you take that toxic load out of your floating volume, it's going to diffuse. So your next TP is going to be ever more efficacious. So that's why sometimes in the really advanced, we try and do it twice a week. You hit it, you allow diffusion, and then you hit it again. And you do that repetitive cycles, you're going to get a bigger bang for your buck, literally.
So I definitely think it would be interesting to see how the Shoemaker markers shift. At the same time, I'd also be very curious how the long hauler panel from Radiance Diagnostics changes, right? I know you're very familiar with that as well, because that is looking at a lot of these cytokines and other things involved in long COVID, chronic Lyme, post-vax, maybe mold as well. So that would be another interesting side project for you. We talked earlier that TPE was more filtration or detox, not so much antimicrobial, but there are, as I understand, some infections found in plasma. So do you find that there is any microbial event happening in terms of TPE, maybe endotoxins, maybe immune complexes that have a microbial antigen, or is there really not any significant or worth discussing component of the microbial conversation relative to TPE?
I think there has to be at least a minute effect on that. I don't think that that's been studied enough. And like you said, I think that's more EBOO based, which is why in some of my people that come in and stay, we just had a warrior come for a month with us, and he actually did TPE and then he did EBOO right after, because you have the two access points, right? So you take it, you clean all your plasma, and then you clean the blood right after. So I think that's probably more where we would get that benefit. But I have to think that removing it, if anything's in there, anything's attached to any of those proteins, we're going to take it out.
So you've mentioned long COVID a number of times. I'm just wondering how your brain or lens sees long COVID. Is it a spike protein issue where we want to then detox or remove spike proteins? Is it an activation of infections like EBV, Bartonella, Mycoplasma, an activation of your mold exposure where maybe we do want to then think about, oh, EBOO may have a role here because of some of these activated infections? Sounds to me like EBOO and TPE both potentially play different roles in supporting someone that might be dealing with long COVID. And then wondering if you think that in some people with long COVID that there could still be a persistent SARS-CoV-2 viral contributor as well.
I think it plays a huge part. And actually, I'm about to undergo my intensive protocol, because one of the things that all of my patients know is I don't make them do anything that I haven't done. And I haven't done the twice weekly TPE, but I'm about to do that. And I'm going to do the radiance labs before and after to see where it goes in terms of those markers. I know that it brings down spike protein. I have no doubt. Just in terms of how I've felt, I had my biggest uptick in terms of symptoms. I had mandatory vaccines at my last workplace. And that's when it feels like it flared everything of mine, any retained mycotoxins, Babesia, Bartonella, all of that. So I think that removing the spike protein while on things to help also get spike protein treated, like I always, if I think that that's it and mold is out of the body, I do a spike protein protocol in addition. But I think this again, it's going to lower how much is in our cup, right? It's going to, if not 50% or more, kind of take that off so that all of the things we use as adjuncts are even more effective. If we take out 50% of spike protein with a TPE, and then we do things, digestive enzymes and nicotine and, other things of that nature, it's going to be huge. And what I notice is that you can do it at a much more reasonable level, in terms of our proteases and everything. So number one, it's less expensive in terms of supplement, overhead, as well as a little bit easier on the body. I feel like it's one of the things that long haul, it's going to be life-changing for people with long haul.
So it sounds like in some people with long haul where they have an activation of infections that EBOO could be supportive for their Bartonella, their Mycoplasma, their EBV, maybe their highly debated SARS-CoV-2, who knows? And then the TPE piece is going to be really where we're thinking more about spike protein detoxification or removal. Is it true that both with EBOO and TPE that we need to use some type of anticoagulant? Most people, we think of heparin, you mentioned citrate. So is that part of EBOO and TPE? And then I think it's also known as ACDA, if I remember correctly, the citrate. So is that possible for a patient to react to the citrate? And could the reason they react to the citrate be potentially that there is a fungal fermentation process that's used to create citrate?
Yes and yes. So in EBOO, we use very low dose heparin in the bag of fluids that is circulating with. Anytime we have blood outside of the body for any portion of time, we need to do something to keep you from clotting, right? The last thing we want to do is try and reduce your clotting risk and then give you a clot. So with EBOO, it's heparin, and it is low dose, but we still are cognizant of it. In our machine, we do use citrate. That was my first question. In fact, when the person came to school us on this, I was like, I'm a mold doc. I don't take citrate because of the interaction. There hasn't been any shown mycotoxin association. Now, I will tell you, if anything's going to cause a side effect in TPE, it's going to be reaction to citrate. Now, we try and manage that. I look at it like a histaminic reaction. We try to manage it, like I said, by pre-treating with dehist, so keeping histamine levels down. Also using an H1 blocker the morning of the procedure so that we don't have that reaction. I don't think that there's mycotoxins associated with it. It makes logical sense. It hasn't been shown. Why I like citrate is contrasted with heparin. If we had to use heparin, the amount of heparin would basically put you at an incredible bleed risk. Whereas citrate, one of the beautiful things about it is most of it is thrown into that bag with our milky plasma because most of it is protein linked. So it's one of those things where it's a great anticoagulant and very little is left in the patient at the end of the procedure. So I don't worry about a bleed risk. When people are driving 6 hours to come see me, obviously the first thing we worry about, gosh forbid, we don't want them to get in any accident. But with citrate, you're going to have a much less bleed risk than you would if you were going to use something like heparin, which is why it's the chosen anticoagulant.
And I'm not suggesting that some sensitive people can't respond or have a reaction to citric acid or citrate because of the fungal fermentation, but I think there is in some cases also a limbic component. If we already know, oh my gosh, this was created by mold, that's going to have the body already in kind of a heightened alert state, right?
Exactly.
You mentioned with TPE that there are some things that are potentially beneficial that are removed from the body as well. You mentioned you haven't seen a need to do something like immunoglobulins or IVIG afterwards. What about things like hormones or nutrients, for example? Is there a potential that after doing TPE that you see someone is lower in hormones or maybe then has a temporary deficiency of some nutrients that were removed from the process?
That's a good question. That is something that hasn't come up, and I haven't even put that on my radar. It is potential. Most of my patients, depending on age, are already on bioidentical hormones. So I haven't heard much about that. I haven't gotten that feedback that they've noticed that they seem to have a drop or, a different dysmenorrhea or anything like that. That's interesting. I mean, clotting factors make sense. Antibodies make sense because that's something that we're targeting. It might be something where in the evolution of this, and as I have more data and more things and more patient feedback, that we do consider, oh, you might need to bump your hormone dose a little bit during this. We might need to eventually consider things like IVIG for a certain patient population, but I haven't seen that need come up yet.
And would we think of TPE as an anti-aging tool? In other words, does it have the potential to reverse biological age? And is that something that someone in the TPE community has actually tested before and after a series of plasma exchanges?
Yes, I completely called it an anti-aging tool. After I get done with my treatment, for spike protein and inflammatory proteins, I don't ever see not doing this. Now, when enaspheresis comes into effect, however long it takes for the FDA to be okay with that, obviously there are some populations that would do better with that, but I see myself doing it either, twice a year, yearly, maybe quarterly, just to take the bad guys out. So I definitely consider it an anti-aging tool. I think things like this are going to lessen our dementia risk. And I think it's super important in terms of creating superhumans and getting us back to where we were before we were exposed for all these crazy chemicals.
You mentioned that you may, in some people, potentially do TPE to do the detox piece and then EBOO to work on the microbial piece. It would seem to me that the microbial piece potentially then leads to some other toxins and things that you'd want to get filtered out. So is it always TPE and EBOO, or do some people do EBOO and then TPE? And then you kind of extending on that, you also mentioned stem cells. What are those doing in this context of EBOO and TPE for your patients?
So I love if I have somebody that is rich, and doesn't know what to spend their money on, which is no one, right? But if you had all of the, people will come to me and I give them different pathways. If I say money is not an issue, this is what I would do. If money is an issue, this is what I would do, and it just depends. So what I would say is my ideal protocol for people would be TPE followed by EBOO in the same session, because we're taking the bad stuff out and then we're hyperoxygenating the red blood cell and what is left. Now, if they're doing one, I like the idea of doing stem cells and or exosomes after, right? Now, if they're doing a series, like when I'm planning on doing 2 a week, I wouldn't do stem cells right after unless there's a time component, like people that are coming in from out of town and really want to get all of the treatment and they want to have multiple stem cells because, again, stem cells are incredibly expensive. But my logic behind this is, TPE grossly is taking out the garbage, right? EBOO is recharging your mitochondria and recharging the blood cell. So even things that, potentially are in the blood cell that are irritating us. And then number three, the stem cells, that's going to give us a pluripotent cell that whatever's broken or missing, we now have the ability to regenerate. And why I like stem cells is because it really gives us everything we need to start all over, right? It gives us, it takes us back to being a toddler, being, right out of the womb. So, a lot of times when we use our own stem cells, we have the potential that they're as broken as we are, unfortunately. So that's why I like the stem cells, because I almost feel like it's planting the seed and then we can flourish and regrow. So depending on where we are, if they're just going to do, they're coming into town, they're going to do a one and done. TPE, EBOO, stem cell infusion. Amazing.
And I'm assuming if you're doing stem cells that you then, if you're doing a series, you would do that towards the end of the series, that you wouldn't want to put stem cells in and then turn around and do another TPE or another EBOO or something, right? That doesn't seem like that would be helpful.
Yeah. Stem cells are incredible, but they're expensive, right? So I always tell people, and their duration, they mature over 90 days. So, I love stem cells and I use them after all of my procedures as long as they're spaced out. If you're doing it once a month for a series of months, stem cells after each one makes sense. If you're doing a couple a week, I would wait for the series to be over and then just give an infusion after the last one.
So many people these days that are concerned about cognitive decline, dementia, Alzheimer's, interested in what you've seen, even brain fog. I mean, probably one of the most common vague symptoms that I'm sure you hear. So have you seen EBOO and TPE helping people with their cognition? And then building on that, if we're thinking about people heading towards Alzheimer's, what's been your observation with other neurodegenerative conditions like MS, Parkinson's, ALS? Do we have any thought that these may be significant interventions in that realm?
Cognitive decline. I mean, when we look at the stats of how many people are going to have dementia in the coming time, for sure. What I tell people is TPE could be the thing that turns it around in terms of dementia. Brain fog is one of the first things I notice that people report is gone after a session of TPE. When we think of all the factors for brain fog, it is multifactorial. So, TPE is incredible for that. And dementia, the thing that stinks is a lot of times by the time we catch it or we diagnose it, it's pretty advanced. So your cost is going to be a lot more. You're looking at a minimum of 6 TPE, more like 12. It's delightful if you can do, 2 a week for a series of weeks. When we look at some of the other neurodegenerative conditions, I got to say I have a whole bunch of them that we're running right now. And what I notice is because it targets bad protein, it works really great at emptying the garbage, but we also have to stop the mechanism that's making the garbage. So in Parkinson's, we have really good research that shows that stem cells helps to regenerate things that are broken and really help with that, especially a series of stem cells. With MS and ALS, these are areas that I'm really interested because I have quite a few patients with this right now that are doing TPE. In addition to TPE and things like EBOO, I do think we need to add things on to stop the body from making the bad protein, right? And doing the self-destructive for the nervous system. So there are certain experimental clinics that are doing things like chemotherapy in low dose to kind of kill that hyper reactivation. These are some areas that I'm dabbling with now. I don't have enough data to give you, but what I will tell you is that TPE, depending on where you are, definitely lessens and slows neurodegeneration. Depending on what we add in with it, it can be life-changing.
And I think I read somewhere or heard you say previously that 6 monthly TPE sessions led to a 61% improvement in cognitive function. Was that correct?
That is correct. That is correct. And I don't think that there's anybody out there that would turn that down. I think that's everybody's biggest concern is losing their mind because The idea of ending up in a nursing home unable to tend for yourself would be horrible. So the fact that we can bring back 61% is incredible.
And we had a listener question around those people with chronic fatigue syndrome, fibromyalgia. I tend to see those more as labels for a symptom presentation, still driven by infections and toxicants. But are there, from your perspective, any unique aspects to those conditions? Would we anticipate that they would also respond positively to EBOO and TPE?
What I would say is, and I always tell people that come in and say they were diagnosed with fibromyalgia in their 20s, I just say that's a garbage diagnosis, right? That's definitely not an investigative practitioner. It's just somebody that doesn't know what to tell them, knows that they have pain. I find that those are all linked to infectious and or toxic toxins, right? So I find everybody with fibromyalgia and chronic fatigue, they all have mold. All of them have Lyme and co-infections. They all have high toxin levels. They all respond beautifully both to EBOO and TPE. So it definitely is a modality that can do amazing things. I don't think there's much unique. I just think it's a different presentation. Is it different than the person that comes in with migratory joint pain and brain fog? No. And probably when you talk to them, they have that as well. So just like neuropathy, that neuropathy that they don't have, diabetes. Why are they neuropathic? Same sort of thing. And they all respond really well to TPE and EBOO.
So you've mentioned the cost of these EBOO, about $1,500 per session. TPE, I believe you said it's around 7,000. I think it can go as high as 10 to 14,000 depending on where people are. I've read that the device just to do this, depending on what people have, can be $250,000 for a practice to bring this in, which is crazy. So it's understandable why these things are expensive, and probably over time, like many things, the cost will come down and these hopefully will be more accessible to many of us. Tell us a little bit more as we're wrapping up about your experiences with EBOO and TPE. What did you see symptomatically that has improved with your health?
I was living in a moldy environment when I was vaccinated for COVID, and then had my two and my booster that were required until I could finally leave the hospital environment and start my own practice. My biggest thing was I went from being able to do Ironman length workouts to barely being able to walk down the hall. And it was probably a combination of the mold activating Lyme, Bartonella babesia, as well as the spike protein joining the mix with all of this. So I also gained 65 pounds in less than 2 months. So definitely that leptin and insulin resistance that kicked in with exposure. So what I've noticed the most drastically reduced has been definite brain fog. It used to be that after that, I would have to write little post-it notes. I had them everywhere, things that had to tie up at the end of the day, something I had to look up for a patient, so, a consult, a referral, whatever. I had them everywhere. After my first EBOO, and especially after my first TPE, that dropped to ridiculous numbers, to how I felt before all of this started, where I was quick-witted again. I didn't have to write everything down. I didn't have to, go back and reverse in my head. And I was I was probably the worst MCAS patient ever. I remember during COVID, I would go into like a big box store like Target or Walmart. And because of my level of sensitivity, if I smelled anybody that was wearing like Bath and Body, or they had Downy on their clothes, or I was in near the pesticide aisle, I would go vasovagal and I would pass out, which was really awkward for people at the store to have to keep calling 911. I'm chemically tolerant now. Now, obviously, I don't love chemicals because they're bad for us. But if somebody walks into my office as a consult and they're wearing perfume, I don't fall on the floor as I'm talking to them. And that came down quite significantly to the point where I don't really even get a headache anymore. And I've gotten a headache from toxins since I was, 4. I remember my dad, lighting up a cigarette and thinking, oh my gosh, I'm going to die. It's been huge for me. Now, obviously, I still work all aspects, right? I still treat myself with, nattokinase and molecule, and, I do all of the things. I just find it's less necessary. Like it used to be that if I missed a day of supplements, I would go into a tizzy. Obviously, I work my Gupta, so I don't, trigger quite as easily. But I feel like my cell danger response has gone down by at least 60% after one procedure. So, and I can't tell you TPE, I noticed a bigger change with. TPE plus stem cells was life changing for me. After my first TPE and stem cell, I got energy back. I felt like in the morning, I actually felt refreshed, which I haven't felt since I was, in medical school in my 20s. So for me, it's just been it's been the biggest game changer. But I understand that it's cost prohibitive for most people. I mean, the reason I bought the $250,000 machine, which you are right, it was about 240, was because I knew I wanted to do this. And a lot of the places I was looking at were 12,000 for a procedure. And I thought if I'm going to have 6 of these and I'm going to have my husband do 6 of these, I'm going to buy one and then I'm going to offer it to all the people that it hasn't been accessible for. And I'm going to hope that as, we get better prices on equipment, because like you said, even just the kit that you put on the machine is almost 1,000, it's like 490 to high 500s. That's just for like the plastic, right? So as those prices come down, as the price of albumin comes down, because one of the problems was albumin was something that was affected. It's made in Asheville. So when we had the crash in terms of IV fluids, albumin went through the roof. So just albumin for the procedure is almost $1,000. So it's all these things. I went into this because I truly want to help people heal, and I will offer it at the most reasonable price. But like you said, even just having a nurse, like right now I have somebody in there, I have a nurse and an advanced EMT with him, and he's been here for 3 hours and he's not done with his procedure yet. So when you consider all those factors, plus the fact that you have to test before and after, there's a lot of cost that's involved with it.
If people are interested in learning more about EBOO and TPE and potentially working with you and your team, can they do a virtual consultation? Is that limited to specific states? And then give us a little bit of insight into your vision about creating a mold-free healing space for patients.
Oh, you're awesome. Of course. This is my baby that hopefully I'm hoping I found a piece of land for the first one. I would say I probably have about 10% of people that come in person, whether they're in Wisconsin or they want to meet for the first time in person, and so they come in. I see people all over the world. I saw somebody yesterday from Thailand. I have people in 12 countries in every state. I joke that between malpractice and my state licensure, those are my biggest, other than my TPE machine, those are my biggest expenses. So yes, you can have a virtual consult with me. I love it. As much as I love seeing people in person and hugging, of course, virtual is that I say that's the one good thing that came of COVID, right? Is that we know virtual works. So yes, people can go to my website, and I'm sure you're so savvy that everybody will know, but our website is thelydaycenter.com. Our practice is called TLC for the Lyday Center and for Tender Loving Care, because everybody loves my staff. They're incredible. It's wonderful to be here. Obviously, most people that come for a procedure come back for a bunch more because they just love it. But you're right, Scott. My idea is to create mold-free healing centers. And like I said, we just found property that I'm hoping we're going to be able to purchase for our first one. So I'm hoping it'll be opening in about a year. My idea is part of the problem with healing is, like we insinuated at the beginning, if I take you and I give you all these healing modalities, but then you go back to a sick home, it's going to be really difficult to see what your body's capable of doing because we're putting it back into a sick environment. So my idea is to have healing centers in my goal is every city where it's a plot of land, and we have a healing center where we offer all of these modalities, whether it's, phosphatidylcholine, ozone, EBOO, TPE. We do hyperbarics, we do sauna, we have cold plunge, we have all of these things. We have trainers, we have access to clean food. And then it's almost like where we all work together, where we have different little houses where you can either do short-term or long-term rentals. And I am working with my indoor environmental professional and my architect to create little homes where you can go, you know that it's safe, and the HVAC is that we just pull that out so that once you leave, with whatever you brought with you, we clean the whole environment so the next family or person that comes in has a safe environment. And we have moderated for, exposure to water, obviously, as well as VOCs and everything else. So we're going to start with obviously the healing center, which is going to be very large. And we're going to have studios and apartments there where people can do short term. And then as we grow, we're going to have on the plot of land, because it's about 20 acres that we're looking at, we're going to have bigger places where people can either short-term or long-term come and stay with us. And then I hope to farm that out to every other state as well.
So my last question is the same for every guest, and the answer could be EBOO, TPE, and stem cells. But what are some of the key things that you do on a daily basis in support of your own health?
So number one, even though I'm busy, I always do my morning affirmations, right? Manifesting, seeing how I want to be on the other side of this. Because as you guys know, this is an exhausting journey. It is long, it is hard, and it feels like just when you get better, something comes up and you're like, oh, here we are again, right? So that's number one. Number two is I try and move my body, just because I tend to have so many virtual patients. I end up sitting for a long time. So I'm trying to get better about blocking my schedule so I can at least get up and move and see my trainer once a week. In terms of healing, I obviously do great with eating clean and doing supplements, but my game changer really is TPE and EBOO, and that's why it's a focus of my practice. I usually do stem cells about once every month to 6 weeks, because I feel like that, in terms of anti-aging, really reverses the clock when combined with TPE and EBOO. So if I were going to wave my magic wand and help each one of my delightful warriors heal, that would be something I would definitely put on their healing plan.
Somehow I think you might actually have a magic wand, but anyway. You have been so incredibly generous with your time today. The universe connected us not that long ago, and I am so incredibly grateful to know you and to know that you're out there. I really want to honor you for what you're doing for your patients, what you're doing for the world. I just think that it's so incredible, and really excited to just continue to dialogue with you and see how all of this advances even more. So thank you so much for all that you do.
You're such a blessing, Scott, because you bring things that people haven't even heard about, and they can learn, and whether they can afford it or do it at that point of their journey, it just opens their eyes to so many things. And you're so insightful and so investigative, but you do it with such a warm heart. It's so delightful. And I'm so grateful to have you had me on this journey today. Thank you.
To learn more about today's guest, visit thelydayscenter.com. That's the Lyday, Lyday, center.com. Thelydayscenter.com. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.